Включіть. Добрий вечір. Пані Оксана, чи ви мене чуєте?
Так, чую, бачу. Доброго вечора.
Доброго вечора. Бачу ще пусте крісло Йорга. Ага, бачу Йорга. Добрий вечір, професор Фегерт. Добрий вечір, професор Скала. Професора Фегерта я не чую поки що. Ага, професора Скалу чую, а професора Фегерта поки не чую.
I'm still muted,
чую.
Sorry.
Чую, да, все добре. І так ми починаємо. І дуже дякуємо всім, хто вже до нас доєднався. Нас доволі багато вже людей на Zoom, більше ніж 175, мені здається. І до того, як я попрошу пані Оксану відкрити, декілька організаційних таких моментів. Момент перший. Для того, щоб отримати сертифікат, не треба нічого писати в коментарях. Буде окремий файл, куди ви все це вносите. В коментарі ви пишете свої питання, бо ми будемо потім перекладати питання для пані Katerin Skala, коли для цього буде час в кінці. І запис буде доступний, бо дуже часто питають, чи буде доступний запис. Так, запис буде доступний і на українській мові, і потім ми викладаємо запис в оригіналі, бо люди по-різному люблять дивитись. Хтось дивиться в оригіналі, хтось дивиться з перекладом. Мене звати Катерина Булавінова, я медичний експерт дитячого фонду ООН UNICEF в Україні і є одним з організаторів цієї серії вебінарів. Пані Оксана, прошу вас, відкривайте.
Вітаю всіх учасників. Я Оксана Zbitneva, голова Координаційного центру з психічного здоров'я Кабінету міністрів України. Ми є імплементаційним партнером всеукраїнської програми ментального здоров'я «Ти як?», яка ініційована і впроваджується першою леді України Оленою Зеленською. І сьогодні наша 11-та зустріч. Зустріч, яка є можливою завдяки тому, що Координаційний центр з психічного здоров'я, Дитячий фонд ООН ЮНІСЕФ і Європейське товариство дитячої та підліткової психіатрії, яку очолює професор Фегерт, вітаю вас, пане Jörg, зробили можливим і доступним для українських фахівців знання сучасні, доступ до науково обґрунтованих знань і експертів світового рівня, яких збирає під парасолькою професор Фегерт і дає нам можливість живого спілкування, можливість поставити запитання, можливість прослухати важливі для нас лекції. Я хочу окремо подякувати нашим учасникам. Це 11-та зустріч. Але щоразу ми бачимо більше, ніж 500 людей, які доєднуються до Zoom-лекції. А ще тисячі переглядів на Фейсбуці ЮНІСЕФ і Координаційного центру. Це означає, що ми всі потребуємо осучаснення знань, і ми потребуємо відповідей на свої питання. І ще один нюанс. До цих вебінарів доєднуються батьки дітей, і ми це бачимо в запитаннях, які ви лишаєте в чаті трансляції. Батьки, які шукають відповіді про складні проблеми своїх дітей або підлітків. І ми намагаємося дати на них відповіді через поширення тих знань і навичок. І дякуємо вам за те, що ви в чаті лишаєте багато слів вдячності. Це надихає всю команду і технічну, яка забезпечує таку технічну можливість наших зустрічей. І я дуже часто кажу, що в простому слові «дякую» дуже багато енергії. Будьте щедрими на це слово, це нас всіх дуже підтримує. Я потім зосереджуся на сьогоднішній темі і представлю спікерку. Я хочу поділитися з вами важливою новиною, яка є продовженням наших зустрічей на вебінарах. Якщо ви пам'ятаєте, у нас був вебінар на тему аутизму в клінічній практиці, дослідженнях та суспільстві, який провів для нас Свен Бельте. І тоді учасники виявили дуже велику зацікавленість щодо застосунку «Контакт». Ми маємо вже рішення щодо доступності цього застосунку для українських фахівців і батьків. Наші партнери з проєкту MH4U вже розпочали переклад і адаптацію цього застосунку, так що, сподіваюсь, незабаром ми його вам презентуємо. А сьогодні тема адикцій у підлітків. Дещо табуйована, незручна, але дуже складна. Ще й тому, що за нею часто-густо стоять втрати, самотність, нерозуміння складних життєвих ситуацій. І, звичайно, вирішення не лише через спеціалізовані послуги, але й через них, а й через соціальну, освітню і інші сфери складові цього глибокого питання, глибокої проблеми. Тож, з нами сьогодні Катрин Skala, вітаю вас, психіатр, психотерапевт, медична експертка психосоціальної служби Відня, яка займається не лише клінічною роботою, а й науковою діяльністю, дослідженнями у сфері розвитку залежностей, або профілактики, або лікування, або протидії, або всього того, що може суспільство з цим зробити. І фахівці, і нефахівці. І, взагалі, експертка в галузі психічного здоров'я молоді. Тож, не забувайте, лишайте свої питання в чаті, щоб ми встигли на них відповісти. Я бажаю нам всім глибокого, цікавого вечора, і нехай нам не заважають повітряні тривоги. І сподіваюся, що всі наші учасники, яких зараз, бачу, 414, знаходяться в безпечних місцях. Всім гарного перегляду.
І зараз я прошу до слова професора Йорга Фегерта.
Thank you very much. Thank you, Oksana Zbitneva, for your continuous support. And it's really true what you mentioned. I'm always impressed by the perseverance of the participants in Ukraine, that in these circumstances, so many people attend our webinars. That makes me very, very glad that we made this effort together to bring that kind of information to the specialists in Ukraine. I also would like to thank Dr. Bulavinova and the UNICEF team, and especially the translators, because they have a difficult job and they bring us in. It's really wonderful. And I don't want to spend too much time, but to add to the presentation of Katrin Skala, she studied human medicine and philosophy in Vienna. And I was very much impressed when we invited her end of last year, to our annual course in developmental child and adolescent psychopharmacology, where she made a wonderful lecture on that topic. And you remember that we had some of the seminars that had been held in English with Ukrainian participants, and we had some German-speaking Ukrainian colleagues with us in Ulm in person, but your webinar had not been translated, and I thought it's very important to address this issue with all your clinical experience and your research experience. So I'm very happy, Katrin Skala, that you are here today and the floor is yours. and we are waiting for your presentation. Thank you.
So, thank you very much for the warm welcome presentation. If it's okay for everybody, and I hope it is, I'll just start and try and use the time well. And I will be trying to give you something that cannot really be more than really a brief insight in the very big topic of adolescent substance use. And when we talk about substance use disorders and substance abuse and addiction, I think it's always good that we shortly be aware that substance use is something we pretty much all do. We depict substance use and festive culture in art, with pictures like this one being called the Feast of the Bean King, this one's being called Nicotine. We have something called just intoxication. This is a bit not Central European culture, but not so far away, just called opium. And at last, we should probably not forget that the moment that Jesus, this is a picture of the wedding of Cana, that Jesus was discovered to be the Messiah the very moment he turned water into wine. So substance use is very much something that's innate into our culture. And what I also like is to get definitions clear. So I'll start with that. What is a drug? We very often talk about drug use, drug abuse, but what is a drug? And there's a couple of definitions, actually. So one definition in the more narrow sense is that a drug is a substance that is subject to the Narcotic Drugs Act. So something that's forbidden by law. And substances of natural drugs can be substances of natural or synthetic origin that have psychological effects or induce states of intoxication. Another definition would be, or a more broader definition would be, that drug is a thing or an action that can trigger a compulsive desire to repeat. So, TV might be a drug, gambling might be a drug, chocolate, stealing, sports, work, sex can all be drugs once they trigger compulsive desires to repeat. So, what else do we need to get clear terms-wise? Use. What's use of a substance or use of something? Use is a sensible and helpful use of a substance or a thing. We have indulgence. We can indulge in things, meaning we're using something that we don't actually need, but that has a pleasant effect. Eating chocolate, for example. Having a glass of wine in the evening. We don't need that, but we like it. If we do that very often, we might become habituated to it. So I'm quite used to having a bit of chocolate after a meal. So I have a habituation for that. This is a result from constant repetition of a behavior. Then we have abuse, which is basically use in a way that leads to physical, psychological, or social damage. So this already has a harmful aspect. And then finally, we have addiction or dependence, which is defined basically as a pathological interaction between a person on one hand and a substance or a fixed behavior on the other hand. There's quite precise definitions of abuse and addiction in the common diagnostic criteria. We have ICD, currently still 10, but 11's on the way, which is the diagnostic tool of the World Health Organization. And we have DSM, currently 4, 5 is on the way, which is the diagnostic tool of the American Psychiatric Association. So those define abuse as damage to mental or physical health of the user without an actual addiction being present. So addiction must be excluded. DSM is a bit more precise with listing a couple of specific situations like problems at home, in the family, or in school because of the substance use. Use in dangerous situations. So driving a car when not necessarily being drunk, but having had a glass of alcohol is basically already abuse. Problems with the law because of substance use, which applies to basically a lot of kids, but also adults, because most of the substances they use are illegal. And once they're being held up by the police, they already have problems. In Austria, at least, if they're being held up with cannabis, they usually let them go again. So they're not being locked in or incriminated, but still they would already fulfill the diagnosis of abuse. And also someone who has social interpersonal problems because of the substance use also does fulfill the diagnostic criteria of abuse. And then finally, in the cascade, we have the addiction, which, and this is something very important for me and something I would really love you to take home with you, if nothing else, which has nothing to do with the amount of substance being consumed. I can be addicted on a very, very low dosage, but the criteria of addiction are craving, so the strong desire to do something, to consume a substance or to perform an act, the loss of control. Like, for example, if I go out and tell myself, okay, I will not drink alcohol tonight, and then still I do. Or if I tell myself, okay, I'll have one glass of wine and that's it. And then it's 4 glasses again. This would be loss of control. I cannot control my actions over that issue. Withdrawal symptoms, and they can be physically, but they can also be only psychologically. We see that a lot, for example, with cocaine. Cocaine addicts don't actually have physical withdrawal symptoms, but very severe psychological withdrawal symptoms. For example, we have tolerance, which means that you need to take a higher dosage as time goes on to have the same effect, because your brain actually memorizes that it's being tampered with the substance, and performs acts of adoption to the substance by changing receptors in the brain. So we're getting used to the substance, meaning we're, for example, not as drunk as we used to be when we have 3 beers, but we need 5 beers to be as intoxicated. We have the neglect of other interests in favor of the use of the substance. So it might be skipping school, or not going out with the family, or not doing things that used to be good, like stopping sports, or not playing an instrument anymore, or not reading anymore, and so on. And we have the persistence of the substance use despite the evidence of clear harmful consequences. And that might be either being thrown out of school, or not so often with adolescents, but for example, with adults, having signs of liver cirrhosis and still going on drinking. So that's the major aspects of addiction. Addiction is, and this is the definition of the American Society of Addiction Medicine, addiction is a primary chronic disease of brain reward. I will get into that later on. Of motivation and of memory and related circuitry. Dysfunction in these circuits leads to characteristic biological, psychological, social, and spiritual manifestations. This is reflected in an individual pathology pursuing reward and or relief by substance use and other behaviors. Reward and relief are those very important words, because one of those is more or less always the reason why we use substances. And we also need to bear in mind that we have substance-related addictions on one hand and non-substance-related addictions on the other hand. Today, I will be mainly talking about basics and substance-related addictions, but especially with adolescents, we have a huge number of addicts to non-substance related things, like gambling mainly, social media, shopping. Some of them are addicted to stealing. This also can lead to an addiction. And within the range of substance-related addictions, we need to differentiate between legal and illegal substances. Within the legal substances, we have coffee, alcohol, nicotine, and we do have prescription drugs. I don't know exactly about the situation in Ukraine, but in Austria, we have a huge pandemic of benzodiazepine use with adolescents. These are not illegal, but they need to be prescribed. So, and there's illegal substances, of course, with all the other ones, so with opioids, LSD, ecstasy, marijuana, cocaine, pregabalin, for example. And with uses of illegal substances, we also have the legal aspect, or we very often have the legal aspects these kids are dealing with. So some of them are in jail, some of them have other obligations from the legal juridic side. So this is mainly something for you to look up. I won't be reading all of this. I just wanted to provide you classification of the major drugs, which are being classified into stimulants, which are meds that increase alertness and attention, energy, but also blood pressure, heart rate, breathing rate, which might and very often do lead to heart problems, psychosis, anger, and paranoia. We have the central nervous system depressants that are generally medications that slow brain activity, are mainly taken by people who want to treat anxiety disorders or anxious states, sleeping disorders, and they do lead to drowsiness and poor concentration, confusion, and lowered blood pressure. Hallucinogens very rarely lead to addiction, very rarely. I have one autistic boy now who considers himself addicted to LSD, but that's in fact the first person I meet who seems addicted to LSD. So these are normally substances that are really being used quite ritualized in order to really have extreme experiences, to broaden your mind, to find out new things about the world and the universe and so on. They very often can also lead to psychotic, but they do lead to psychotic experience, but these might linger, and we only have a problem then, basically. Alcohol, still, at least in Austria, the most dangerous drug, the most widely used drugs, also a central nervous depressant, meaning it slows down the function of the central nervous system, and mainly reduces inhibitions, leads to motor impairment. I think most of you have some experience with alcohol, and you will also know the long-term effects like alcohol use disorders, health problems mainly concerning the liver, but also the brain, and alcohol increases risk for certain cancers. Cocaine is a very powerful stimulant drug that's very activating, increases self-confidence, and that's the main reason that people need it. It also narrows blood vessels. That's why we quite often see heart problems, not so often in adolescents, but in adults we quite often see heart attacks or ischemic strokes because of the very narrow blood vessels. And because it's mainly taken by the nose, we very often experience troubles there. So nosebleeds or nasal damages and trouble swallowing because of that. Well, and then we have heroin, and this is it's an opiate, but it's a very special opiate because it is very quickly leading to respiratory depression and is, because of that, very lethal. We unfortunately have quite a lot of deaths due to heroin mainly, also in minors in Vienna and Austria, because it's very, very potent and it's leading to respiratory depression. People don't realize that actually they're dying and they just stop breathing. Methamphetamine is a very stimulant, very, very potent stimulant that's chemically related to amphetamine, but has a very strong and far stronger effect than amphetamine. People feel very much awake when they take it, can be physically active for days without sleep. It decreases appetite. That's the reason for some to take it, to slim actually, but most take it just in a way, sometimes for fun, but also to increase their wakefulness and their possibility to dance all night. Actually, it does very often lead to anxiety and compulsive disorders also, quite often to hallucinations and delusions. This is probably a good moment to mention so-called research chemicals or new psychoactive drugs. They're not new anymore. We know them for 25 years now, but these are a vast number of drugs that are being fabricated in laboratories. They are very similar to drugs we know, but just very similar. And there's a couple of 100 substances known, but we don't know effects, we don't know side effects, we don't know toxic or lethal dosage, but they are on the market. And with many or most of them, we cannot even find out when people have taken them, because the drug tests we use are not screening for them. Just because there's so many of these substances that we would need new drug tests every other week. And so we cannot screen for them. And the kids are not only the kids, but kids buy them in the internet. They think they're safe because they come in funny, colorful packages. But in fact, no one knows anything about what is inside actually. And so, and I'm mentioning them now because most of them are either close to methamphetamine or close to THC, so the tetrahydrocannabinol, which is the main component of marijuana. So marijuana as such is taken from the hemp plant, Cannabis sativa, is a very well-known drug that's been known for decades, and basically a recreational drug which enhances sensory perception and euphoria. A lot of people use it, but we have about 30% of the 15-year-olds that have once tried it, so it's really something quite common, and basically not a very big problem. But on one hand, there's kids that use it really to treat some other disorders, and they might actually really get addicted. And on the other hand, we perceive a huge increase in concentration, or we have perceived this increase, which has taken place during the last, say, 10 years. And when in the 80s, average concentration of average THC concentration in cannabis was around probably 5%, we now have 30 to 40%. And this is something completely different. And this also is the reason why we see a lot more psychotic disorders as a consequence of cannabis use. Well, and finally, we have opioids other than heroin, which are pain relievers, are chemically close to heroin, and they do cause euphoria and are very often used non-medically. Those also can lead to overdose, but the danger of overdose actually is biggest when used intravenously. This applies for heroin as well as for all the other opioids. I will try and jump to specifics in brain development, because for me, it's always been very helpful to know about and to always bear in mind what's going on in an adolescent brain, because it makes it easier to understand and actually to tolerate what those kids are doing. And even the kids are interested in finding out what's going on in their brains, and what makes them so unstable in a way. So some basics are that during adolescence, more than in any other time of our life, there's so-called synaptic pruning, meaning that synapses of neurons, so the bits where those neurons have contact with other neurons are being reduced. Those that are not in use are being cut off in a way. So during adolescence, we lose about 3% of our gray matter substance, which is quite a bit. On the other hand, there's something called myelination, which means that those neurons, those synapses that are being used, are being prepared to last forever. So they have an extra layer, or they are getting an extra layer, which makes them more stable and more efficient. Meaning, the things you don't use are being lost, but the things and the structures you use are being prepared to stay. And all of this is being processed in a way that starts in the back and finishes front of your brain. And the problem is that in the front of your brain, frontal lobe, resides your center of impulse control. So brain is being reconstructed during adolescence, but the place where you should know what to do and what is wise to do, whether you should really have another beer with this test at school tomorrow, is not awake yet. It's still at age 9 or 10, while the rest of your brain is very quickly turning 13 and 14. So this is why teenagers are actually very responsive. They have a high appetite for risk. They have a very low risk assessment. They have a low capacity for reflection and anticipation. They are very vulnerable, and I'm meaning the brain, because when they consume drugs, the drugs pathway are being fixed. They are being built to last forever. And we have some kind of double jeopardy, because kids are very responsive. They have a high emotional reactivity and very immature cognitive control. And third is that their brain is reacting to what they're doing. So what is the so-called reward circuit? If you look at the picture on the left side is the frontal lobe, so your front, and on the right side is the back of your brain, and would be the back of your head. So in the frontal lobe and the midbrain is the center for addiction. So addiction is that's where addiction actually happens, in the so-called mesolimbic reward system. This is also the place where we encounter positive reinforcement, classical conditioning, associative and emotional learning, and all substances and things that can lead to addiction lead to dopamine release here. And another not so good news, adolescents' brains are more sensitive to this, so their dopamine release is stronger, their peak is higher, and so they have a stronger urge for so-called sensation seeking. They want to feel this. And so talking about dopamine is basically the drug that makes us feel good. Dopamine is the drug that lets us know that everything is okay, that we are great, that the world is okay, that problems are not so big after all, and that we can just relax. And so this is something we all actually want. And drugs boost the normal brain levels of dopamine, which produces just pure pleasure and increased energy. But drugs can also cause excessive spikes in dopamine, and those spikes can actually lead to and do lead to the destruction of brain cells. And there's something like dopamine index measuring how much the dopamine release increases when we do or take something. And so, in case you wondered, if you have a cheeseburger, your dopamine will be higher by 1.5. If you have sex, it might depend on the quality, but your dopamine in average should double. Same applies to having a cigarette, so twice as much dopamine as before. If you take cocaine, you have more than 4 times the dopamine you had before. And if you take methamphetamine, you have 11 times the dopamine levels you had in your resting state. So why would anyone bother with the cheeseburger when he or she could have methamphetamine? And as adults, we actually have a reason or two why not to take methamphetamine. But if you remember, adults do not have impulse control. So they are far more likely to just go for methamphetamine because it's just so good. And their brain tells them so little reasons, gives them so little reasons not to do it. And another another thing that makes addiction very understandable, at least for me, is that the circuits where drugs are active is the same circuit that makes us survive, basically, because eating, bonding, and sex actually do release dopamine in this very circuit. So this is a very tricky thing the brain does to make the species survive. If we have sex, if we eat, if we bond with our kids, it releases dopamine. So this makes us feel good. And so we want to do it again. And so the species will survive if we go for food and sex. So the brain remembers this and wants to repeat it. And another thing, substance use as such induces physical changes in areas of the brain, especially in circuits that are critical to judgment, decision-making, learning and memory, and behavior control. For those of you who actually have listened carefully, this is something I mentioned as features that adolescents are not anyhow brilliant in. So adolescents do not have any specific capacity for judgment and decision-making or behavior control. And now if they take drugs, all these features are not being developed, actually, but altered to an even worse state than they were before, which gives us a vicious circle, because with an even worse judgment making, the next consumption of a substance will be even easier than before, because the brain will even less talk or say give us information about the possible dangers of the substance or the consumption. Just a quick summary on dopamine and substance use. Dopamine is a neurotransmitter that's being released during a pleasurable experience. It's connected to the reward circuit of the brain, and it acts by reinforcing the behaviors that are pleasurable, so we want more dopamine. But it does lead to neural changes that help form habits. Really in the neurons, it makes change the way the neurons are connected. And spikes can actually even destroy the brain. And it's being released during substance use and reinforces the connection between the substance and the pleasurable experience. So it trains the brain to repeat the pleasurable experience. So this training actually leads to craving and to the very difficult situation that we really need to conquer the craving once we want to stop this. Okay, just a small picture to show you the effects of this with the example of methamphetamine on the brain. And here in red, you see dopamine receptors, green, yellow, and red. You see the density of the dopamine receptors in a healthy person. So there's a bit of red, quite a bit of green, in the middle there's yellow. And the second person is someone who used methamphetamine, but has already been abstinent for 1 month. So you see there's not much red. So this person has a lot less dopamine receptors than the healthy person, and so a lot less pleasurable experience than a healthy person. But for the good news, these receptors come back, but you need to be abstinent for a year or longer. The middle brain and the right brain are not from the same person. On the right, but with the right brain, you see someone who really has gotten quite a few holes into his brain. So this is just also to stretch the fact that methamphetamine and other substances can actually really get you a mental brain, basically. So what is a cycle of addiction? You can start anywhere. Normally, you would start with a ritual and using the substance. So you're getting used to it, but then you might not feel good. And not feeling good is quite a strong emotional trigger to actually consume a substance, because it makes you feel better. So you're not feeling good, you crave the substance, you do it again. And this is becoming a ritual again, and using a substance because you're not feeling good is becoming a ritual. And this is more or less how addiction develops. So you might start with just using it for the pleasurable experience. A lot of adolescents do not start that way. They already start with kind of treating aversive emotional states by using the substance. And one thing that's also good to know is, or to bear in mind, that young people's worlds differ from those of adults. Young people they have the need to develop their identity. And so they have to try a lot of things, and they have to do things that are forbidden, and they have to do things that are not good for them. They have to find out who they are and what they can do and which borders they can actually cross. While adults normally have some kind of health awareness. Youth are living here now. They have no idea about the future. They don't care about the future, while adults are more used to think in long-term consequences. Youth want to enjoy, they want to discover, they want to find out how much they can drink before they need to vomit, whereas adults normally see an enormous consumption as rather problematic. With adolescents, immoderate is cool, and with adults, it's rather negative for most of them. And now we come to something that is a very important thing for me and for those people, those shrinks working with kids who consume substances. And actually, almost all kids do consume some substance or other. And if it's only alcohol and a bit of nicotine, they all do, because they have to find out what it does to them. It's kind of almost something they really need to do when growing up. And so what we actually do, psychiatrists, we ask them for their reasons for consumption, because those who consume because they like the feelings, they want to experience novel feelings, they want to have a great party, they want to enjoy the evening with their friends, they want to feel new sensations. Those are not the ones that are endangered in the first place, but those who consume, which you see on the right-hand side, to consume to feel better, to feel less anxious, to have less worries, to not be so fearful, to be less depressed, less hopelessness, to be able to sleep. Those are those who are on the border to develop a problem. And we are, in our daily practice, really focusing on this group. And it's very important to focus on substance use already with kids and adolescents, because that's when the first use initiates. 67% of all teens have already tried marijuana once. And actually all drugs are being consumed for the first time on average before people turn 18, even heroin, of course, by those who do consume it. But even heroin is an average consumed for the first time shortly before the 18th birthday. So it's really important that we focus on this issue already with minors. I'll give you a couple of slides, and it won't be very much longer, but I'd like to give you a couple of slides on epidemiology with kids and adolescents. So cigarette use has been decreased quite dramatically, but a couple of years ago, those performing those studies found out that there were things, or there are things that are replacing cigarettes. And so you see the dotted lines on the left picture. This is the first investigation that's also asking about snus, pouches, vapes, water pipes, and so on. And then when we include those, we find out that the decrease in cigarette consumption is not actually a decrease in nicotine consumption. If we look to Europe, this is about what epidemiology of nicotine looks like. So we have quite a north-south increase with Scandinavian countries, and actually Portugal and Spain, Germany quite low, but Central and Southeastern Europe quite a high prevalence. With alcohol, lifetime alcohol use by gender, when I'm talking about 15 and 17-year-olds, everybody knows it. So 90% of adolescents have tried alcohol at least once in their life. And between 50 and 60% of adolescents use alcohol at least once a month, so once in 30 days. With alcohol, we have a clear cut with Scandinavia. So Scandinavia has a very strong oppressive policy, and so there's really hardly any alcohol consumption of adolescents in those countries. But we have those who are dark red, are countries where youth say that they consume alcohol at 7 or more occasions a month. With cannabis, it's quite stable over the last years. The left picture is a very important picture because it depicts the users that are 13 or younger when they first tried cannabis. And here we really know that this is a very dangerous thing, as cannabis actually implements changes in the brain that are irreversible when consumption starts early. And early means under the age of 16, and it's not consumption as such, it is frequent consumption of quite a high dosage. But someone who starts consuming cannabis frequently in quite a high dosage at the age of 12 or 13 is very likely to have irreversible impact in brain development. And the right picture shows lifetime use of cannabis by gender in the 30 countries. So it's an average of 30 countries. And there you see that girls are a bit lower than boys, but 10 to 20% actually do know cannabis all over Europe. With cannabis, interestingly, there's not the same trend as with nicotine. We have the rather higher consuming countries with 11 to more than 15 occasions in 30 days in Spain, France, Italy, Austria, Czech Republic, Belgium. And when we look at illicit or prescription drugs, situation is quite stable with around 5% of adolescents who have tried illicit drugs other than cannabis once in their life. And what is even more shocking to me is that also 6 to 10 or 9% of all kids have already tried prescription drugs. For new psychoactive substances, it's a funny picture color-wise. So we have a center rather Czech Republic, Poland, north, and the other countries are not so affected. So why do some people get addicted and others don't? I told you about motives, and this is a strong indicator for us to find out what risk a person has. But some other thing that I would be happy if you took it home with you, so to say, is that the drugs are one thing, but the other very important thing when we talk about addiction is the receiving brain. And you will ask yourself what this picture does in a presentation like that. There are, in fact, people who investigate spiders on drugs. And they put them on drugs and watch them how they build their webs. And left above, you see a sober spider building a sober spider web. The middle picture in the upper row is a spider on chloralhydride, which is a barbiturate, which is not available on the market anymore, at least in Austria. So spider is very tired and falls asleep after starting to build the web. Similar effects on the spider has Mariana, whereas the spider still builds a bit of a net before falling asleep. Spider on ecstasy is a lot quicker than the spider on Mariana. There's actually films to this, but the net is quite comparable in terms of architecture. What you do not really see very well, I'm afraid, but if you look in the right above corner, you can imagine that the spider on LSD is actually able to build the best spider web you have ever seen. This is a very, very precise web. So any spider basically should take LSD if he or she wants to build a perfect net. And the personal Armageddon for a spider, brain-wise, seems to be cocaine. So this doesn't even look like a spider net. So what I want to say is that it's always an interaction of a substance or a behavior and the person who consumes the substance or performs the behavior. So it's not a single factor that determines whether someone will become addicted. We know of a lot of factors. We have genetic factors that might account for up to 60% of a person's vulnerability to addiction. And we do know, and we really try to pamper those kids. We know that kids with addicted parents are really endangered because they have nature and nurture not in favor for them, saying that they have a genetic predisposition, and growing up with parents with an addiction is not usually funny. So they see that problems are best to be coped with by means of drugs, and very often parents who are not sober are not always very good for their kids. So those kids are really endangered, but the genetic factors, they are one piece of the puzzle. Parents and all the family members are very important, and so seeing them using or not using drugs actually does a lot to the persons. We know that the earlier consumption starts, the more likely people are to have an abuse or addiction problem later on. And the method of administration is important. There's a difference whether I smoke heroin or I inject it, because the peak in dopamine will be different. And the higher the peak in dopamine, the higher the addictive potential. There's environmental factors, of course, that are important, like stress, traumatic experiences. Those kids I've been dealing with during the last years, who really have a huge problem at the age of 13, 14, 15, all have had traumatic experiences in their childhood. So this is a very clear correlation. And of course, peers who use drugs or abuse drugs are a risk factor. So this is just to make it a bit clearer. There's a lot of interactions between biology, genes, environmental factors, the drugs, brain mechanisms, and if those work together in a non-favorable way, they might and will lead to addiction. So why do adolescents take drugs? They want to show themselves and the world that they're already big. They do it because they belong to a certain clique, that's a certain peer group that consumes. Consumption might be a symbol of participation in certain youth cultural lifestyles. They are testing cross-border experiences. This is one of the factors they need to actually do during adolescence. It's often a means of expression of social protest and criticism of social values. And it might be a deliberate violation of the norms of the parental home. This also is actually a task of adolescents, violations of norms of the parental home. And these factors actually are okay. So if kids tell me, okay, I vomited in the living room and whatever. And if they're okay, if they go to school, if they say, okay, I vomited at home, but the party was great, I had fun, it might be okay. But we are worried about those who tell us that they actually had to take this or that because they had a failure experience again. They had to suppress stress. They needed to go to sleep for once. Those who consume drugs as a reaction to social or developmental disorders, to consume them in an attempt to provide relaxation or compensation for disappointments. Those are those endangered of addiction. So what is a problematic consumption behavior? Regular, frequent consumption of high dosage, functional use. If you don't remember anything of tonight, please remember functional use, self-medication. Those are those kids who are in 99% trying to actually treat a psychiatric disorder with drugs. Mixed use, we have in Vienna, we see a lot of kids and very young kids, 12 to 13 years old, who actually take what they get. They don't, as they used to 15 years ago, they don't define themselves as cannabis users or cocaine users or heroin users. They say, okay, whatever my dealer provides will be fine. I'll take what I get. And if we really want to find out where those kids stand, how endangered they are, we should actually focus on the motives of consumption. What are you taking? What are you taking? Not what are you taking it for? Why are you taking it? Where? When? How often? With whom? How much? Then to really focus on what they're taking. That's not so important. So does drug use cause mental disorders or vice versa. We do not really know. We know they coexist. And in my experience, drug use worsens mental disorders, but a lot of kids I got to know during the last years are actually already had a mental disorder, which they were trying to treat with the drugs when they started. What we do know is that 50 to 75% of all clients in counseling institutions do have a coexisting psychiatric disorder. So, substance abuse is a treatable disease. It's preventable, it's treatable, but the treatment needs to be highly individualized, and it entails medication in most cases, behavioral interventions, and also peer support. We need most of those kids who have really had a drug problem for a couple of years. They kind of need a new life. All their friends consume. They lost all the friends from before that period. They lost more or less their life. Not their life in a narrow sense, but their surroundings. And so treatment of this disorder, these biobehavioral disorders, is not just fixing the chemistry. We need pharmacological treatment in most cases. We very often need medical services because a lot of those kids are sick. They have infections and so on. We need behavioral therapies and psychotherapies, and in most cases, we need social services. And so the treatment process usually entails, if possible, identification as early as possible, brief interventions, a comprehensive assessment to determine extent and severity of the disease, stabilization, timely and appropriate substance use disorder treatment with addressing substance use disorders, but also the co-occurring issues, and the continuous care, which means for a lot of people, more or less lifelong care to help them stay sober. And most people who have a withdrawal do not stay sober for all their lives. They do relapse now and again, but it doesn't matter, because if they are being held by the system instantly, normally they will be able to get back to their life as they had it. Just one thing, very briefly, DSM-5 and ICD-11 will stop to diagnose addiction in a dichotomous way, but they will have a gradual diagnosis. So with those new diagnostic schemes, you can diagnose a mild addiction, a moderate or a severe addiction, depending on the number of criteria that are being fulfilled by the person. So something else that is very helpful to me in my daily practice, I'm telling it to myself very often, almost on a daily basis, because it helps stay focused on the kids. They do have low impulse control. They have no tolerance for frustration. They are very likely paranoid, delusional, agitated, or depressed. And so they have a high risk of explosive and violent behavior. And it's not because they're not behaving, it's not because they're bad, it's because they're sick and because their illness made them be so. Their illness and adolescence made them be like that. Very often they have strong craving, cognitive and memory impairment, and a very brief attention span. So our daily practice is offering kids to come, realizing that very often they do not come. They might show up intoxicated 2 days later, do not have an appointment, but still we're kind of happy because they show up. They show up in a time where they're very sick without knowing it, because most adolescents who consume substances, at least at first, have no concept of illness. They feel okay. They are okay. They don't want any treatment, but what for? And so we're happy if they show up. We need biopsychosocial treatment. We need medical detox, anti-craving medications, treatment of comorbid medical and psychiatric disorders. We need psychological treatment, motivational counseling, CBT, intensive outpatient treatment, psychoeducation, family therapy. And in most cases, we need social treatment. So we need aid with education, housing, very often foster care, because very often families either don't exist or the kids have already been in foster care when they started consuming, or parents just threw them out after a couple of years of consumption. And I'm already almost done. I just think this is a very important picture. And then I will give you a couple of examples of how to actually engage in a conversation with a consuming kid. This is the so-called cycle of change of Priaska and Di Clemente, saying that any addict, and not only addicts, you might go through these cycles with other problems or issues as well, but any addict actually goes through these cycles. And very often they go through these cycles very often. So at first, someone's not actually has no problem with this behavior. Then first doubts arise. So is it really okay what I do? Am I probably drinking too much? Should I smoke less cannabis? So this would be pre-contemplation. Or this would already be contemplation. Once you're aware of a problem, once you tell yourself, okay, no, actually probably I should change something. Then you would go into preparation. So you intend on taking action, and actually you go into action. You take an appointment with a counselor, with a drink. You modify your behavior. Then you need to maintain these modifications. And then very often you might relapse. I don't know if any of you actually already sometimes stopped smoking and probably relapsed. So, but then you might think again, probably I'll try again. And many people, and especially adolescents, go through this cycle a lot of times. But if they are getting better with every cycle, this is as good as it gets for the moment, or it might be as good as it gets. So I'm just quickly giving you some ideas on how to talk to those kids if you want to make them go to see a specialist. So you just might engage them in a discussions that really helps you get an understanding of how those kids see their use, and to explain what benefits they have from their use, and if they have any second thoughts, anything that's probably not so good in their point of view. And so you might be more likely to understand their mixed feelings and to help them raise their level of motivation for treatment. And once you did that, it's always very helpful. And this is really something kids tell us, to summarize for them. For example, so you're saying that, drinking's bring you down, messing your relationship with your family, but on the other hand, you're not, you don't feel like you're able to change something. Is that about it, or where you're standing? And this is something I've really heard very often from kids saying, okay, the way you helped me reflect my thoughts was so new, because everybody else just said, you're bad, you need to stop it. You're doing something bad, and I order you not to do it. So if you try and find out with the kids where they stand and what might help them, it's a way to get their trust and to actually make them open some kind of door to you. And then you might ask, what would need to happen to make them motivated to change something? And then again, you might summarize for them. So it's hard to know what could happen to make you feel more motivated for counseling. Some people get motivated because things get worse. Others get motivated because some things get better, because something good happens. Is there anything that relates to you? Is anything of that happening in your life? It's just basically about getting in touch, getting into a relationship. That's the only thing that really actually helps in working with adolescents. And then you might start something like a referral conversations, saying, "Oh, we've talked about your struggles at home, schoolwork, and with your health, and changing something about your alcohol behavior, your alcohol consumption might help." And then in the audit, which is alcohol use disorders identification, you score 13 out of 40. That's indicating that cutting down a bit might make things better for you. What's your idea? What do you think? So not ordering them, because they feel very oppressed usually when they come to see you first. And then you might also say, okay, I'm glad that you want to make a change. If people say, I need to change, I want to change something. So would you be ready to see a specialist? Because in my experience, specialists can actually help you a lot better than I do. And you might need to make this conversation a couple of times. So I'm really starting to close now. Treatment basics. Substance use disorders are basically lifelong diseases. Some people can recover and lead full lives, but it's also very likely that they will have relapses now and again, because substance use disorders are relapsing diseases. And this is why they need ongoing treatment, which doesn't mean that someone goes to counseling 3 times a week for 40 years. But I have patients who drop in every other month saying, okay, I'm okay, don't need anything, bye, see you in 2 months, which is okay, but they know I'm there for them. I know that they're fine, and that's it. And general, better than treatment in any case would be addiction prevention. So it's also very good to focus on that in delaying the start of substance use when we can. This needs a consistent implementation of youth protection acts, role model behavior of parents and caregivers. It needs advertising restrictions for psychotropic substances, and it would need an outlawing of excessive alcohol and drug consumption. A promotion of responsible use of alcohol, promotion of enjoyment and functional equivalence, and a health-compatible festive and celebration culture. And this is where I am stopping for tonight, and I thank you very much for your attention, and I'm happy to ask your questions. Thank you very much.
І зараз ми переходимо до запитань. Не знаю, пані Оксана, ви чуєте мене чи ні?
Так, пані Катерина, тут.
Добре. В нас є декілька запитань, тому я їх, як завжди, зачитую українською, а потім перекладачі будуть всю історію цю перекладати. Наприклад, пані Оксана Фіцак питає: у світі збільшується кількість підліткових суїцидів. Чи це якось пов'язано з вживанням наркотичних речовин підлітками?
So just to understand correctly, the number of suicides in adults is rising. Is that what you said?
Підлітків.
In adolescence. There's always a connection of substance use and suicide. Almost always. But it's very hard to give a general judgment of the way of connection, because I've seen, unfortunately, very often seen both ways. Adolescents who are very depressive, traumatized, suicidal, who use substances only once they are already very depressive. But on the other hand, substance use also leads to depression and a proneness to suicide. And there's one more thing that I think we should bear in mind. Countries might probably not document adolescents' death very precisely. I know in Austria, we are missing a lot of adolescents that I knew that have died of an overdose in the statistics. So I don't know where they have gone. Some of them might be ranked as suicides, but I know, at least for a couple of them, that they never ever committed suicide, but it was an accidental drug overdose. So we don't really know if some of those suicides might actually be accidental overdoses, but there is certainly a connection in both ways. There's a connection between the substance use does lead to does lead to suicidal behavior very more often than not using substances, and severe psychiatric disorders that are as severe as to actually make people develop suicidal thoughts very often lead to substance use. So they are really connected, those two.
Наступне питання задали англійською, тому увага перекладачам, я його зачитаю англійською. І так, please clarify, do you use a motivational interview or do you prefer a classic clinical survey of adolescent patients with addictions?
Actually, we have a huge suitcase of tools and things we do. Yes, all my team is trained in motivational interviewing. But what exactly we do with the patients very much depends on the person that is coming to see us and on the person he or she is seeing. We know that the one factor that actually is working out is relationship. In adolescence, it's all about relationship because the kids don't have a working frontal lobe. Adolescents are in their mindsets, they're living forever. They will never die. And they don't care whether they might actually die from an overdose. So you cannot not really treat them or deal with them in the same way as you can deal with adults, in really depicting the problems they are facing right now and they will be facing when they continue their behavior. Adolescents don't care. So the only thing we really can do is to become a significant caring adult. I don't know if this term is familiar, if you're familiar with this term. This is a one adult person that they know of will be there for them in some way or other. And a lot of the kids that we are dealing with don't have that at home or anywhere else. And it doesn't mean that we're becoming mommy or daddy, and we shouldn't, and we know we shouldn't, and we are very careful with that. But for a lot of kids, we are the only person who is actually there for them, even if they're drunk, even if they have consumed again, even if they stole mommy's purse again, even if they are being thrown out of school. We're there, we're not judging, we're describing, we're trying to help. I mean, of course, we're judging if they are coming in with weapons, if there's silver linings or red lines. They know there's a couple of things that they are not allowed to do here. They're not dealing, or that they must not deal, they must not have weapons. But we don't judge them for relapsing. And so, if it's useful, it's motivational interviewing. If it's not useful, we're just going to McDonald's with them and having a hamburger. So anything that's needed.
Пані Віра Дзобас питає, які наймолодші пацієнти із залежністю вам зустрічались у роботі?
The youngest who really was addicted was 11 years old, who had a severe opiate addiction. But you need to know that this is a kid that grew up with two opioid addict parents and has grown up from his youngest age in a place where almost anyone present was on opioids, and foster services didn't realize for a very long time. So he was taken from his family, I think, when he was 6 or 7, and he started actually injecting heroin when he was 11. But that was a single case. Now we really do see a lot of 13-year-olds and 14-year-olds who consume benzodiazepines, alcohol, ecstasy, and quite a few of them heroin. And in Vienna, currently, the younger ones very often only smoke heroin, which is not quite as bad as injection, but normally it's just one step before injection. So 13-year-olds who smoke heroin are really worrying us a lot, and we see a lot of them now.
Пані Віра Дзьобас далі питає, чи існує профілактична робота у школах щодо залежностей? Хто проводить цю профілактичну роботу? Лікарі, психіатри, педагоги? Хто?
Well, there's two things. One is existing for a long time, and that's some task forces who go through schools and are doing like kind of an info day, something like that, which is something. It's good, it's important, but it's not really effective, because addiction prevention does include information, and it has to be honest information. It's no use telling kids, if you consume cannabis, you'll die very soon afterwards. And then they try, they find out they are still alive, and they won't believe anything else you say, or adults will say. But still, it's important to have honest information on what's what. And something that we also have, which is very valuable, is we have something called Check It, where you can go with your drugs and actually have them tested in order to find out how strong the concentration is, if it's actually really cocaine or just flour or rat poison. And so this is, of course, in animals. The kids scratch, people who analyze must not touch the drugs, which is, that would be forbidden, but the kids scratch little pieces of it and they have them analyzed. And those buses are at festivals, at parties, and so on. That's very good, and it goes along with information. Know your stuff. Because we will not manage to have kids not consume drugs. We can manage to have kids not die of overdoses, and in order to do so, we need them to know what they take, and we need to make them aware that they should know what they take. So that's only one thing. And the other thing is that we have teams, and this is quite a recent thing. We have teams going to schools, and mainly to schools where problems are more frequent, any kind of problem. Social problems in the families and so on. And so there's teams of social workers, psychologists, and therapists that are going to those schools and are actually talking with the teachers, and can really work with a couple of kids there to find out if they need support. And this is not drug specific. This is not consumption specific. It's before. These might be primary schools. This might be 11, 12-year-old kids. But this is, in fact, an incredibly important thing in terms of addiction prevention, because all those kids who really have a problem, I think I might have mentioned it once or twice or 3 or 4 times, most kids who have a problematic consumption behavior at ages 13, 14, 15 have had severe problems in the years before. And so this is something where we try and get to those kids before they start consuming or before they start to develop a problem.
Пані Оксана Фіцак питає, яку мотивацію ви знаходите для підлітків, щоб переконати, прийняти вашу допомогу? І який відсоток приймає вашу допомогу?
Okay, the motivation is we provide a lot of people who listen without judging. So, and we don't accept anything. We don't expect anything from them. So most kids think, okay, they need to go to see the shrink. Oh, God, they need to stop doing everything, and we'll wave our index fingers and we'll reproach them for their behavior. And then they're quite astonished when we don't. When we offer help, not help in stopping to consume, because 90% of kids who come to see us for the first time have no intention whatsoever to change anything in their behavior because they don't see a problem, but to find out where their problems are, to find out if we can provide support of any kind. And then they might come in for the first time and be astonished, and then they might miss 2 or 3 appointments, but suddenly they call and want another appointment, and they say, okay, I've been thinking, and it was nice talking to you last time. I think you cared. I still don't want to change anything in my behavior, but could I talk to you about, like, my dad beating me and what I could do? And so it's always from, we mainly come from this side. Hardly ever we see kids who come to see us and say, okay, I need to get off heroin. We do have those too. But in most cases, we're not starting there. We're starting with a relationship and gradually go to find out where they are in their life, what their problems are, where they might need help. And then alongside, very often it turns out that might be useful if they took less benzodiazepines or if they reduced ecstasy and so on. But this comes with working on anything else.
І питання теж від пані Оксани Фіцак. Який відсоток підлітків в Австрії лікується до стабілізації стану, до того, що вони не вживають потім? Чи є така статистика?
There are no statistics, but I can give you my impression. It's very rare that during adolescence, kids really stop consuming, and we often have the discussion when we mention the word abstinence. Kids also say, so what do you mean by abstinence? Nicotine, caffeine, sugar? What's abstinence for you? So, and it's true. Yes, we want too much of kids. If you also want them to never ever have a beer or have alcohol, what's abstinence? So we need to define a goal, and we usually define this goal by anything but alcohol and nicotine and caffeine and chocolate and so on. So, and a lot of kids actually get very close. So it's very difficult also to measure the outcome, because we are okay if someone who was used to about 2 grams of heroin a day intravenously from age of 14 years to 16, and then stopped heroin, benzodiazepines, and cocaine, and smokes a joint every other day and consumes ecstasy once a month. I'm fine with that. Honestly, if they go to, and it's not so much what they take, but if they continue, or if they are establishing a life, if they go to school, if they're fine, if they're okay, and if they have a joint every other day, okay, I let them be. I might still work on the joint issue half a year later. I don't know if this is understandable, but we are not. With going along with the European trend, we're not so much focused on abstinence in the field of adolescence, because we will be losing a lot of kids because they're not basically interested in it.
Пані Ксенія Сачук питає, які ліки проти тяги призначають дітям та підліткам?
There's no epidemiology, there's no evidence. There's no evidence for any effect of any substance, like evidence, grade A, B, C. But we have reports of a couple of substances that are working quite okay. Most of them are neuroleptics, basically, because of course we're using substances that are not or do not themselves have an addictive potential. So we might use quetiapine. I don't know if it's common in Ukraine, or clothiaxepoxid might be one of those substances. And this is reported to really reduce craving by a lot of kids. Depending on their state, on their underlying disorder, on their comorbid disorder, we might use other things. I have a patient who had a severe heroin addiction, really severe, who almost died 4 or 5 times, who actually takes a bit of trazodone whenever she has a lot of craving. Did you know trazodone? Antidepressant, sedating antidepressant when she has cravings. So something we do is to really try and find out what kind of substance helps this specific person for craving. This is not the same for everybody.
Ще є в нас таке питання, і ваше ставлення до замісної терапії.
Opioid replacement therapy, was that?
Like methadone, for example.
Yeah. We do it often. And in Austria, it's actually, this is something we're even a bit proud of. In Austria, it's easier than in other countries. And it is easier to get adolescents on replacement therapy than it is for adults. Because in Austria, adults need to have undergone at least one attempt of withdrawal before they can be put onto replacement therapy. For adolescents, it's sufficient to have the diagnosis of opioid addiction to put them on replacement therapy, like methadone or Subsidol, buprenorphine. And there's 2 reasons for that, or there's mainly one reason for that, that we need to get the kids, all those kids naturally have a very short history of addiction. It comes naturally, because if you're 14, you cannot have consumed for 30 years. And given the shortness of the addiction, it is relatively easy also for the brain to try and forget it. But we need to get them out as quickly as possible, and we need to get them out of the peer group as quickly as possible. And that's why we fought for this possibility, and we have it, and we are offering it very often. And astoundingly, a lot of kids actually don't want it, because they want to manage staying sober by themselves. So we have bizarre fights very often where the doctors actually, where I feel I'm actually forcing someone to take opioids in really proposing replacement therapy. But still, some take it, some don't. And in any case, we are always making a plan, of course, of reducing that too. So we don't have any kids on replacement therapy for decades. But very often it's a useful step on their way to regain back the life they used to have a couple of years before.
Пані Ірина Яворська питає, часто зустрічаємо різке підвищення залежностей серед підлітків на деокупованих територіях. Можливо, ви маєте приклад організації роботи в громаді для допомоги дітям та підліткам на фоні великого стресу. Кого б ви залучали до такої роботи в ком'юніті?
It's a difficult question. I know who I would involve if I had someone in the community. I mean, one very important thing are the families. I'm not sure if I'm answering the question in the way you intended it. I mean, two aspects. Once within the community, it would be very good to have a couple of players, like to have schools on the table, to have generalists, to have pediatricians, kind of informed on basics in treatment, in motivational interviewing, but in talking to those kids, and to have all those people with a comparable mindset. And bit of a different thing is that it's very, very important to have the families involved, because very often parents are desperate and are rapidly changing between overprotection and throwing the kids out of their homes, because they are so desperate, they are so afraid that their kids will actually die, and like unfortunately very often they actually do, that they don't know what to do. And most parents feel very guilty and are not able, within this huge amount of strong feelings, to have a constant mindset towards their kids. So once they might lock them in, and the next day they will throw them out, and the day afterwards they will excuse themselves and go on a holiday with them, and to throw them out again when they come back because they stole or consumed or whatever. So what we find to be really important is counseling for parents. We're doing that too, completely independent of the children. We also counsel parents whose kids are not being treated at our place. But of course, we also counsel parents whose kids are being treated here. And that's very important.
Пані Ольга Юдіна питає, чи повинен лікар повідомляти батькам-підліткам, якщо дитина просить нічого не казати батькам про те, що він або вона вживає наркотики?
I can only tell you the Austrian legal situation. There's a difference between a so-called mündig and under and over 14. There's a legal difference in Austria. If you're 14, you have certain 14s and older, you have certain rights that you don't have if you're under 14. If you are under 14, parents need to be informed that you have had an appointment. We don't even have to do this with kids 14 and older. We don't even have to tell the parents that the kids have seen us, and we do not have to tell them that they consume substances, but we do need to tell them, in both cases, any age, if their life, in our opinion, is endangered. Then we need to tell them. And these are very often quite awkward discussions with the kids, and they are often quite angry, but very often afterwards they say, okay, I was really angry, but I think it was good you did what you did. Because we're telling the kids, okay, I am worried about you, I'm worried about your life, and I need to inform your parents that in my opinion, your life is endangered. I'm not going to tell them about your consumption, because you asked me not to, but they will ask you why I might have the idea that your life is endangered. So is that probably a good moment to tell them what you're doing? And quite often that's actually a bit of a turning point. Once kids actually open up to their families, it might be a big chance. So I hope this kind of answered the question, but this is just the Austrian legal situation.
Пані Оксана Міхняк питає, які наркотичні речовини мають вищий ризик виникнення психозу чи тривожного розладу у підлітка?
Which have the highest risk? Okay, it's highly dosaged, highly concentrated cannabis, and it is most of all synthetic cannabinoids, and of course any hallucinogen, because those are actually an LSD trip is a psychosis. And for someone prone to psychotic disorder, this increases the likelihood for this person that this disorder will just stick, or this kind of perception, this mode of perception will just go on the way it did. So basically, it's synthetic or highly concentrated cannabinoids, and might be ketamine, of course. But these psychoses, these psychotic disorders, normally decrease very quickly, and it's also anything that's hallucinogen, and quite a few of the so-called new synthetic drugs.
Мгм. Я задам тоді ще 3 питання, і ми будемо завершувати, бо вже доволі пізно. І так, питають, пані Тата Дворяковська питає, як підтримати підлітка в нікотиновій залежності? І чи поновлюються рецептори потім, після вживання нікотину?
I'm asking with this. I'm starting with the second part. Yes, basically they do recover, but the brain will. I stopped smoking more than 20 years ago, and I know that I could just start like that. I know I could start again, and I probably would if I had a cigarette. I don't have the idea, never had, but I somehow feel that my brain still has some kind of memory of it. And so the receptors recover, like on the pictures I showed you, they do, but some memory, they stay prone to restart the program they actually had once the person had an addictive problem, and they are able to really change their setup very quickly once the good old drug is finally coming back. And then the brain circuits actually really form a huge craving cascade transmitter-wise. So yes and no, the brain recovers, but it stays with you. And first part of the question, what do we offer to kids who want to change their nicotine consumption? Well, we evaluate what the problem is, if there's an aspect of biological dependence or not, and depending on the kind of the problem, on the aspect of biological addiction or psychological addiction, we will offer them a behavior problem and or nicotine substitutes like chewing gums or other substitutes, as inhalers and a lot of products, but within a protocol. Not just like there you have them and just go ahead and save the money you would spend for cigarettes.
Пан Андрій Лохматов питає, ви кажете про невідворотні зміни, які спіткають підлітків, які в ранньому віці регулярно вживають наркотики. Про які невідворотні зміни ви говорите?
There's very sound data only for cannabis, unfortunately, and these data are sound and from a study that actually was a prospective study of almost 40 years with a huge set of adolescents, and there the authors found out that there's a lot of defects in the development of executive functions. So to say, anticipation, memory, planning, and also basic intelligence. So the average kid that consumed a large amount of cannabis before the age of 14 had a decrease of 8 points an average 8 points in their intelligence quotient, which is a lot. So it's actually general intelligence with a focus on executive functioning, so concentration, long-term concentration, memory, spatial memory, also a lot of aspects.
І останнє питання буде від мене на правах модератора. В Україні дуже широко в соціальних медіа наразі дорослі обговорюють фільм, який вийшов нещодавно на Нетфліксі, який називається Adolescence. Питання, чи обговорюють його в Австрії, і чи обговорюють його лікарі, і про що саме він для вас, і що важливого про це. І може є рекомендації про якісь ще фільми про підлітків, які ви вважаєте важливим подивитись лікарям, медсестрам та психологам?
We have how many times left? No, wow, that's a very interesting question. Yes, we do discuss it. It's being discussed in the media. It's being discussed amongst shrinks. And well, the baseline of the discussion is it's very well done. It's very real. Well, very realistic. Especially, I don't know who of you has seen it, especially the way the boy was played was extremely precise to a lot of things that we see. A kid that commits a murder, that's not aware of what he's doing, that's lost in social media space, and still it's very, in the way it's described there, it's quite dystopic, because it has for me it has it looked as if watching the kids in this school, it looked as if everyone was just like that and just lost in World Wide Web space, which is not what we experience. But of course we know this kind of kids, we know that, and they are there, they do exist, but it's just not all of them are like this. And yes, we have a long and we have a continuous discussion about smartphones and restriction of smartphones. Australia restricted smartphone use, and we have a restriction in at least primary schools. So up to 10-year-olds, finally, they forbid smartphones in school. So this is kind of a very present issue, or it covers a lot of present issues. And the kids don't actually, I haven't met a lot of kids who actually brought it up. So I think the kids don't watch it so much in Austria.
Я дуже дякую вам за цей вебінар, пані професор Katerin Skala. Дякую пані Оксані, яка була з нами до кінця. І будемо закривати цей вебінар. Дуже дякуємо всім учасникам. Пані Оксана, пару слів від вас на кінець, і ми закінчуємо.
Зрозуміло, що тема, яку ми сьогодні торкнулися, от ми просто привідкрили. І мені здається, ми маємо говорити, пані Катерино, про те, що нам ще не одна лекція, не один вебінар з цієї теми були би дуже корисними. І з огляду на кількість питань, які були і від фахівців, і видно, що від батьків, я би дуже хотіла, щоб ми продовжили розмову на тему адикції у підлітків.
Дуже всім вам дякуємо. І будемо на сьогодні завершувати. Дякуємо, Katerin.
Thank you very much. It was a pleasure. And I'm really happy. I think this is such